Okay, this is a first of its kind episode here for the Ortho Show podcast. We're bringing on Dr. Jawad Saleh, who is a PharmD, which is a PhD in pharmacy. Really a hotshot guy, man. He's got a lot going on. He is basically the clinical manager of pharmacy services at HSS. So what does that mean? It means that literally he runs this pharmacy team, and these pharmacists are part of all of the aspects of healthcare, whether it's in the intensive care unit, they're part of the operating room, and they're basically a part of the team when they're rounding, and they bring their expertise of pharmacy to the clinicians, which basically really amplifies and improves the patient care. He's passionate about opioid sparing, and we talk about that, about a lot of the modalities that are available as well. And really, I think it's a fascinating episode for you to be educated on a part of healthcare which you may not know. It was a pleasure having him on. This is Dr. Scott Sigman. Hashtag follow the fro.
From Medical Media, this is The Ortho Show.
Hello world, Dr. Scott Sigman, your favorite opioid-sparing orthopedic surgeon, here for another episode of the Ortho Show podcast, where everyone knows we bring you the best of the best in orthopedics. We are super excited. We are going to have our first pharmacist on the Ortho Show, Jawad Saleh, who's a PharmD, which is basically a PhD in pharmacology as a pharmacist. He's the clinical manager of pharmacy services at the world-renowned Hospital for Special Surgery. He's also an assistant clinical professor at St. John's School of Pharmacy, and he is one of my go-to opioid-sparing superhero pharmacists. Jawad, what a pleasure it is to have you on the show.
Should I be wearing a cape? What's going on here, man? You got me excited. I feel like I could take over the world.
You got the cap, you got the white coat, man. You got to keep the cape under wraps, man. That's what we do.
Hey, I have no hair. I got to wear the cap, and the coat is to, keep the body in tune.
It's a good contrast between you and I, for sure. I love that. So listen, we always start at the beginning on the show. We always like to know where our guests come from. So, where were you born? What's your story? Are you the first, PharmD? Are there doctors? How did you get to where you are today?
Honestly, I think I'm a perfect example of an underdog. I'm sure there's many stories like mine. I mean, we're in New York City where, I grew up, born and raised in Brooklyn, New York. I'm the son of Palestinian immigrant parents. My parents worked really hard. I would go back and forth to the Middle East. They'd take me when I was a kid. I didn't grow up really with a silver spoon. I did grow up with a hardworking dad that helped me, a mom that came from somewhat of an educated family who really came to this country and continued to study. So I don't want to take away from them, but I grew up on Atlantic Avenue. It's in Brooklyn, and it wasn't very easy at times, of course. But in a very weird way, I wouldn't have it any other way, because it really, when you make it out, you are resilient and you feel really good and you can take on the world. And believe it or not, I know this sounds really weird. It really helps you in the corporate world, and it helps you in a room full of different personalities, because you've learned to be around that so much.
We've heard that a lot. The children of immigrant families whose parents come over, who do the extra struggle to make sure that their children, as the next generation, could be more successful, than they are. So, you're in this environment, but yet you worked hard. Your parents had, great expectations for you, and you didn't want to disappoint either. And so you worked hard, you study hard, and next thing you know, you're at St. John's University studying. And was it destined at that moment that you had an idea as to what your long-term strategy or plan was?
I was in high school. I wasn't sure at the time. I've had family members and friends come out of hospitals or clinics with prescription medications that were addicted to them or had issues because of them. I was really fascinated to some degree by why this was happening and what caused this. And then, you'd walk over to your own neighborhood and you walk down the street. Again, you know how New York is. You could be in a great neighborhood in 1 second and bad in the next. And you see people addicted to drugs and chemicals that are causing these reactions. So I was really interested in the pharmacology side. I left high school at, I think it was 16, a year and a half early, went to St. John's, started pharmacy, and I really liked the whole field.
That's interesting because, in that time, if that time frame, we're knee deep in the opioid crisis. We've got Purdue Pharma, you've got J&J, you've got all the big pharma companies that are sort of, not, I don't want to use the word pushing because I don't want to get people pissed off, but there was no question that there was opioids were being touted as the solution for pain management. And we didn't understand it, right? Why are all of these patients addicted to medication? Are they bad people, right? Or they're not making the right decisions, or they come from the wrong side of the tracks, and that's how this happens. But that's not the case, right? Opioid addiction doesn't care about your bank account or your zip code. If you're destined to it, you're going to get it. And so in 2002 or so, when you're at St. John's, I mean, you're living there, you're in Brooklyn, you see it. But yet at the same time, there was no explanation as to why. It was the standard of care, right? We're providing opioids for everyone perioperatively for long-term pain management. Didn't matter. We're going to give you opioids. And so I think it's interesting that you chose very early on in your surroundings that you wanted a pharmacy career to understand why that was happening.
Yeah. And it was, it's interesting because, you got to look at us as a society, right? I'm leaving to Ghana next week. I was there 6 months ago, and the tolerance for pain, that culture, that community is so different than our top. So I asked them, I don't understand you guys. I went to the supply chain issues, and we spoke to the health advisor to the president of the country, and what's going on? You guys can't get hydromorphone, or what's happening here? What are you guys doing? And it's no, we can. And it's, I don't understand. And it's like, they tolerate it. It's just, they tolerate. And again, I don't know to which threshold or level does it become ethically sound, but they just tolerate it more. They handle it and deal with it versus, we just want everything, done and comfortable, and it's almost unrealistic expectations, which we're getting there. We're getting there with strategies and innovations.
Yeah, we're doing better than we have. And, so what you're describing is that, in Ghana in particular, patients, if they have surgery and other things, they just deal with their pain. There's no automatic prescription of opioids. My dear friend Michael Redler and I, as part of One World Surgery, have been down to Honduras. We're going back again in December. We operate on these patients. We're doing 4 to 5 patients per OR per day in 3 operating rooms, and no one gets opioids. It's just not done. I mean, we'll use long-acting anesthetics to help them with their initial pain for the first 24 hours or so. But literally, you give them Tylenol, and there's no anticipation or expectation of opioids. So it really became a uniquely American, phenomenon. So, all right. So do me a favor. First of all, let's educate our listeners. Okay. So people think of pharmacists, they think of CVS, they go in, they put their prescriptions in, but, you have an established extended degree. You're a PharmD. Basically, it's a PhD in pharmacy. Describe for our listeners as to what the process of that is, and then what you do that is so different and unique than your average everyday pharmacist.
Sure. So, not to discredit them, retail pharmacists are amazing. We need them. They deal with a lot, and they have a whole different skill set. I decided to go into more of the clinical realm, the more clinical operational realm. And what does that entail? It entails getting almost a specialty in a specific field. I'm board certified in critical care as well as pharmacotherapy. We have specific specialties. There's residencies when you want to get into this. There's a clinical team in a hospital pharmacy, for example. I like to call them the Navy SEALs of the pharmacy, right? We go into this, the code blue signal ones. We have an infectious disease pharmacist. There's different pharmacists stationed everywhere. I helped build that in HSS. So we got our team here. I started off the first decade here in operations to understand purely just operations. The last 7 years, I've built out the clinical team and the clinical pharmacy program. What that also entails is some quality, of course, a lot of quality metrics. And I think the next chapter is going to be more in the leadership realm, clinical leadership, to help oversee and make some of these decisions that should be happening from the top down.
No, I love that. What a wonderful explanation. And I think that, the clinical operations side of pharmacy, and I love your Navy SEALs analogy. as we become more expert at things, it becomes a much more narrowed field, right? So as a shoulder expert, I know everything there is to know about the shoulder. But if you're in a trauma, the trauma doctors know everything there is to know about fixing all bones. But the way in which those 17 different pharmacologic agents may be going on in a patient that's in an intensive care unit, how they all interact is your area of expertise. And you can walk in and bam, be able to explain to them. And you're making rounds with the teams, right? You're providing that counsel day to day, which really elevates the games of the physicians that you're working with and provides really the best possible care for patients. So kudos to you in establishing that at HSS.
Thank you. I think also, what ends up happening too when you're in this field is the more you're involved, the more you get involved in research and innovations as well. So you just keep taking it up a level as you go. You learn it, you understand it, you give your expertise, your ideas around it. And like you said, yes, you're in direct patient care is more on the clinical side. You're rounding on a daily basis. And I'm in the operating room regularly in and out all the time. So yeah, it's a whole different.
Yeah, it's a different species, man. And it really makes a huge difference. And I do some consulting with pharmaceutical companies, and when I do, when I get up there and I give my talks and sort of explain on the clinical side of what I'm doing, man, is it cool to have one of you dudes on the panel with me when they start asking the hard questions about the pharmacologics of the medications. Like, no, let's let the hard questions go over to Jawad for sure. But no, that's really great stuff. So appreciate that for sure. So Jawad, so let's roll the camera backwards to like 2012. You've been in practice now for 5-6 years. I'm in as well. I've been doing it for about 7, 8 years. And just the opioid crisis was just in full swing, right? It's the nurses with pain being a vital sign, and questionnaires going out to patients, and JACO telling us we have to treat our patients' pain with opioids. And we just had so many patients that were really addicted to opioids, but we didn't understand it. We didn't know why. And then all of a sudden, there's sort of a transition where there's some new medications come out, long-acting anesthetics, but they were really hard to push through because people didn't want to pay for them. What was your experience back about a decade ago?
The experience changed dramatically. I think the culture's changing. I think there's more awareness. In the past, PNT is the Pharmacy and Therapeutics Committee, and that's really sort of like the police of the organization of bringing in a medication. Pharmacy has a lot of weight in that committee. It's a multidisciplinary committee. And now with these EROS protocols, right, enhanced recovery after surgery, the multimodal trend that's in every organization that they've been pushing to cut down on opioids, innovative ways and new medications have been the wave of the future and what's been happening since. And that's the difference.
It's interesting. When I first started doing some talks for liposomal bupivacaine in particular, it was rotten tomatoes, man. I'd walk into a dining room or a restaurant, and there'd be like 4 people there, and I'd start talking about opioid sparing. They look at me like I was crazy. Like, why do we need to do that? Like, what's the problem? And then slowly and over time, with people understanding and clinical pharmacists like yourself who can really review the data and the literature and be able to demonstrate that spending some money on the front side of the epidemic will save us money and lives on the back side of the epidemic. I was just down at Shoulder 360 in Miami, a wonderful course with shoulder surgeons from all over the world. And I just was sitting there in the audience, and there were 4 shoulder surgeons up there talking about opioid-sparing surgery as part of what they do with, 400 people in the audience. And I was just smiling, thinking to myself, how far we've come in a decade to be able to message that people really believe in it now. And we have leaders like yourself that are out there on the pharmacy side that can prove that this stuff really does matter. Breaking through all of the silos of pharmacy and those things, and understanding that, the ER is connected to the hospital where you may have people that are having opioid addiction issues. And so you're losing money in there as well in the hospital. But yet, if you use more expensive medications, we can hopefully prevent some of those opioid addiction issues as well. So let's talk a little bit about your thoughts on some of the evidence that's out there right now, right? Because you're really out there with your team evaluating the literature to really say what works and what doesn't work. So tell us what are your thoughts right now on some of the opioid sparing tactics that you're using at HSS to be able to help out with your patients?
One of the, I think here, we're really big on regional anesthesia. And one thing in pharmacy school that really isn't taught much is anesthesia or regional anesthesia and nerve blocks, right? And I think that, believe it or not, it's somewhat of a boring topic to most of us, but we've been using different types of blocks and being created. But we've also utilized, on certain occasions, different EROS protocols for different surgeries. And also, we've been using, a bunch of different medications. We've used Zin Relief here. We've been piloting that medication here. And we're using installations and different types of infusions. We've started utilizing a lot more of Precedex in the hospital. Ketamine is making another run for its money. It used to be the bad drug to give, and now it's becoming more common in specific cases.
So give us an explanation about how Precedex and ketamine work differently. My mother Judy's listening, so she's interested, but she didn't go to medical school, so we got to give it to her.
Ketamine's MDA, so ketamine doesn't work as much on the mu receptors. There's a lot involved with the respiratory depression that comes with ketamine. It actually alleviates that. There's a lot that occurs with your blood pressure, right, or your intracranial pressure. So there's a lot of benefits that come with it when you use it. It's a different mechanism, and they're not as sedated as well, depending on what dose you're using for which patients. So that's pretty cool. Precedex is dexmedetomidine. Precedex, if you're in the pharmacy world or you've been in this world, it's similar to clonidine, but it's more selective. It's an alpha-2 agonist. And it really works really well. But initially, we used it just in spine cases, so we can wake them up versus giving propofol and do the neurological checks. But now it's used for everything. It has its analgesic effects, the sedative effects, even for alcohol withdrawal now they're using it.
So interesting. So a couple of different medications that have a different mechanism of action than what we would typically see with opioids, for example. You mentioned the mu receptor, which is where the opioid's attached to. So it's functioning in different ways. And then you sort of use a combination of these things, and then you minimize the opioids, which are addictive. Precedex and ketamine are not going to necessarily be addictive. They don't have those, same issues that we're concerned about. You mentioned Zin Relief. I did a total knee replacement this morning on a patient. We operated on her at 7:30. She had an adductor canal block with a regional anesthetic, and then we used Zin Relief inside the knee, which is the gel that we put in, which is a long-acting anesthetic. And she looked at me an hour after her surgery, smiling at me, fully dressed, couldn't be happier. We did a little quick video together, and bada bing, she's out into the car and on her way home. So really remarkable, how far we've come, even when you started, right? Patients were spending 3 days in the hospital, and then they go to rehab for a week after a knee replacement. It's unbelievable how different it is now.
Everything is turning ambulatory, especially with it's becoming more of an ambulatory game. And then you start having to think about reimbursement with patient care. It's changing, and I think it continues to change.
Yeah, no, I think that there's, nobody wants to go to the big white building with sick patients in it, right? The hospital. Everybody wants to be done, especially with COVID. We recognized, why do you want to have a knee arthroscopy next to someone that has, some sort of an infection, right? You want to be done. Healthy people should be done in a healthy place away from the hospital. So there's been a lot of moves. And I think that, pharmacy is so important in that. We can't just send people home and just say, you're going to be okay. You got to provide them a pain solution so that they're comfortable in the process. One of the things that I see that really needs to be fixed or sort of be worked on is the efficacy gap. We're pretty good now, with Zin Relief, we get out to about 3 days, liposomal bupivacaine, depending on who you talk to as well, as far as that time. But what about, 3 days now? One of the companies I'm really excited about is Gate Science, which is developing a catheter that will allow regional anesthetic to go through as well, but also has neuromodulation, which will help to reduce, pain around those nerves for upwards of perhaps 30, 60 days. Any thoughts as far as that's concerned?
We haven't used it, heard of it. Really good innovation. Most of I'm not sure if that's typically, we've been using the outpatient catheters, with a bunch of its complications. Of course, it has pros and cons, but it's absolutely something we are open to. I mean, there's so many different technologies coming out and medications coming out. The hardest part is funneling through which is beneficial and which isn't, and patient safety.
Yeah, I mean, the No Pain Act, I think, is going to be pretty interesting, right? You're familiar with the No Pain
Yeah.
Act. It was written into the omnibus spending bill, so it came through as law now in January, which is truly going to open up the possibility of, reimbursement for opioid alternative treatment options in that perioperative window. So it'll be interesting to see what type of new devices and things are going to play their way down through the list. I'm sure you're involved with some companies that would like your expertise.
Absolutely.
Yeah, no, fantastic. So, we're just sort of thinking aloud at this point, so where do you think we're going? What's the next stage or phase of pain management within the world that you're seeing that's going to really help our patients as we progress through the rest of the next few years?
I think telemedicine and, digital health is really the future. And I know they're bringing up AI a lot. I'm a little skeptical about that, but I know that eventually we'll get there. But I think, it's funny, we keep thinking of newer medications, which there's some great ones, but sometimes going back to the basics of giving acetaminophen and ibuprofen on discharge, or utilizing ketorolac when you can, and going back to the older medications, actually are extremely beneficial. So I think what it's going to come down to for the future is a combination. And I think it's going to take the surgeon, it's going to take the anesthesiologist, and it's going to take the pharmacy in a collaborative effort to figure out what protocol works best for that specific procedure.
No, I think that's exceptionally well said, right? I think that's where we had some real problems as we were trying to change the paradigm of postoperative pain management. The disconnect of the pharmacy, the disconnect of the anesthesiologist wanting to do it their way and the surgeon wanting to do it their way. I think that Zeb Kane, a dear friend of mine, who many people know within the value-based management and the perioperative college, really talks about his perioperative home and bringing all of the team members together to make sure that everyone is providing that same message so that patients can effectively, safely undergo surgical intervention and hopefully not become addicted to opioids.
One thing that I usually like to talk about that I would love for whoever's listening to really think about is if you are in an organization and you don't have an opioid stewardship committee, really, really, really consider it. I mean, Joint Commission is coming in and asking questions about this. The reason why I say this is you can take a pain medication to P&T, which is pharmacy and therapeutics, the police of the organization of bringing meds in, and you're going to have one, maybe two specialists in pain on that committee. You're going to have the pediatrician, the oncologist, whoever it is on the committee. And I think having the specialists, 15 or 20 in a room from different disciplines, review a pain medication, new or old, or a protocol, and then accept it and bring it up to the pharmacy and therapeutics committee makes the world of a difference, because when it gets there, they know that it was approved by the professionals or the experts in this field. And it makes it a lot easier to consolidate or at least to pass things through.
No, I think that's absolutely wonderful and sound advice. I think that, Jawad, it's really been a pleasure having you on the show, giving us the unique experience of a clinical pharmacist in a large hospital setting and the important work that you and your teams are doing to contribute to the healthcare and also to really help to try and minimize the exposure of opioids to our perioperative patients. And so it's really been a pleasure having you on.
Thank you for having me. I appreciate it. I'm the first pharmacist on the show, Scott. So
you are the official Ortho Show alumni pharmacist of the year. There's no question about it, brother. We appreciate you so much. This is Dr. Scott Sigman, #FollowTheFro, host of the Ortho Show. Till next time.